This lecture is about conducting needs assessments. So your learning objectives are to describe the purpose of needs assessment in program planning, to list the steps when conducting needs assessments, list reliable sources of information for needs assessments, and to be able to conduct your own needs assessment in order to describe the context for the intervention, including the population, setting, and community. So needs assessments in program planning are part of step 1 of intervention mapping. A needs assessment is a systematic study of the discrepancy between what is and what should be. It's also a statement of a problem. It can be real or perceived, and it's sometimes referred to as formative research. What a needs assessment is not is a solution to the problem. Most importantly, a needs assessment helps us to identify the determinants. The determinants, as defined by Green and Kruder, are the biological, psychological, and social factors that are found to be associated with the behavior or environmental condition that has caused or influenced the health problem. They are causally related to the behavior and the environmental conditions, though empirical data may be lacking, and they should be modifiable. The logic is causal based on theory, but empirical evidence may be lacking because studies are cross-sectional or correlational. So in conducting a needs assessment, part of it is to develop a logic model of the problem. As was discussed in the first lecture in this class, this is a logic model of the problem, which is a modified pre-seed model from Green and Kruder. Again, this model starts at the right in phase 1. So I'm going to lead us through an example here. So in terms of the quality of life indicator in phase 1 for this example, we're going to call it premature death from cancer. This is for our particular target population. And then for phase 2, we've been able to identify through empirical data, literature reviews, and what we know from epidemiological studies and research that obesity and overweight are contributing to that premature death from cancer. At the societal or community level, we know that lack of access to fruits and vegetables is what is contributing to some of that obesity and overweight. It's not the only thing, but it's one of the things contributing to that. And at the individual level, that then results in poor self-monitoring and diet. These two things are related, that because individuals have little access to fruits and vegetables, individuals are not able to eat many fruits and vegetables, and they lack the ability to really monitor their own diet. And then in phase 4, some of the personal determinants that impact the ecological levels, the environmental factors, are the community's beliefs about food and diet. And at the individual level, we see low self-efficacy. So basically meaning individuals don't have much confidence in themselves in being able to monitor their own diet. So once you have all of the indicators for each of the phases in the model, working from phase 1 to phase 4, and it's completed, then you could read your logic model of the problem from left to right, and it shows you a causal model of the health problem and quality of life. So when we read it from left to right, we see that low self-efficacy for healthy eating and the community's beliefs about food and diet are what contribute to poor self-monitoring and diet and lack of access to fruits and vegetables, which all contribute to high rates of obesity and overweight, which then contribute to premature death from cancer. So sometimes in health promotion planning, you don't get to decide where you start. You might not have the opportunity to do a full-on needs assessment and begin with a quality of life. So you might be given a project from your department, or maybe from a funder, or maybe because of a grant, and you might have to start in a different phase. So in this example, we're going to start in phase 2. So we've been told by our funder that they want us to work on obesity and overweight. And so that instead of starting at phase 1, we're starting at phase 2. But in the same way, we still have to go back and identify our quality of life indicators. And then we go back to phase 3 and finally to phase 4. So agencies that employ program planners are often funded within categories of health problems. So for example, there's the American Cancer Society, different NIH institutes that are all focused on different health problems. And so sometimes even within behavioral and environmental factors, so for example, there's an organization called America Walks. And so their focus is on the built environment and walking. So they might have a project and they want to improve walking in the community. Well, as a program planner, then you'd be starting at phase 3, but you still have to go back in and fill in phase 2 and phase 1 before you identify your determinants in phase 4. So when you're conducting a needs assessment, the first thing is to describe the priority population. So who is your priority population? Who is the intervention meant to affect? So even though a lot of people might be involved in the intervention, the implementers, the organizational leaders, community, environmental, whose behavior at the end of the day are you trying to change? And who is this meant to benefit? So you identify the numerator, so this is the number of people who participate, and the denominator, the number of people in the population for whom the program is intended. So this is known as REACH, developed by Glasgow, Vogt, and Bowles. And then, of course, you have to think about the environmental context of the at-risk group. So once you know who you're thinking about, who you're targeting, then you think about the different levels of the social ecological model that might impact that person's health behaviors. So at the interpersonal level, there's individuals or groups that have close connections to members of the priority population, and they're very likely to influence health behavior. So, of course, family members are very important, but so are friend groups, work groups, any other social individuals that might impact a person's health behaviors. And then at the organizational level, these are systems with specific objectives and formal multi-level decision-making processes. So for example, clinics and the way they work might impact a person's health behaviors. At the community level, these are systems in which people link together in social networks and can contribute to causes and cures for health problems. Sometimes community groups are chosen, so you might choose to be part of a community, and other times they're just dependent on where you happen to live. So for example, census blocks. And then at the most broad level of the ecological model, the societal level, so these are larger systems that have the means to control several aspects of the lives of the population. So for example, state government. So policies that are put forth through the government impact the health behaviors of the population. So when you're conducting a needs assessment and you're thinking through phases 1 and 2, so the quality of life indicators and the health problems, you want to ask yourself, what is the health problem? Who has it? And what are the incidence, prevalence, and distribution of the problem? What segments of the population have an excess burden from the health problem? And where can the groups at risk be reached by a program? So in your videos from Linda and Keisha every week, they're giving you some clues into which target populations they want you to think about, and they've given you specific zip codes to look at. So you know which segments of the population you're supposed to be targeting, but you need to do the research and look at epidemiological data to find out what is the incidence, prevalence, and distribution of the different health problems in that community. And then you're going to do a demographic description of the health problem in the target population. So rate is really the number of events, so people with a health problem, over time per population. So the incidence, of course, is the new cases of a problem in a certain time period, and prevalence is the number of existing cases. So you might hear, frequently you hear counts about the flu season each year. And that's really incidence, because every year those are new cases of the flu. Prevalence would be the number of existing cases. So the number of people currently in San Diego living with HIV. So that would be prevalence. So when you're comparing rates across groups, something to consider is whether or not the health problem is more or less prevalent in this community than in others. And is this an important health problem in a specific community? So is it defined by geography, culture, or other demographic factors? And I would say don't always focus on the numbers, even if they seem low. So for example, you might see that the prevalence of a particular health problem, high blood pressure or heart disease, is, I'm just making up numbers here, like 20% among the African American population. And you might think like, oh, that's not that high to have only 20% of the population on blood pressure medication. But if you were to look at African American population in San Diego compared to other ethnic and minority groups in San Diego, and if everyone else's blood pressure rates are below 10%, well, then that's a huge disparity. And so then that is an important health problem in a specific community, and then there's a disparity there. So when you're then describing the possible causes of the health problem, so identifying what those risk factors are, and these can be behaviors or environmental conditions that affect the health of the population. And many interventions focus on individual behaviors, but really the environmental conditions tend to have a significant influence on health behaviors. So sometimes it's easy to think, oh, well, people have high blood pressure because of their diet, or because they're not exercising, or because they're smoking, but there's a lot of environmental factors that might contribute to those behaviors. So living in a food desert where there's not access to healthy food, poverty that limits ability to purchase healthy foods, stress from low-paying, high-effort jobs might cause someone to smoke more so than someone else who has access to other ways to relax and engage in self-care. So those are some of the things that kind of think beyond the individual level responsibility and into the other levels. So when you're describing the behavior of the at-risk group, you want to think about the dose-response relationship between the behavior and the health problem. So for example, unprotected sex leading to increases in sexually transmitted infections. So there needs to be a really clear link between that behavior and the health problem. And then in terms of describing environmental risk, you want to think about the 4 levels of influence: interpersonal, organizational, community, society. So for example, if a clinic lacks cultural competency leading to low compliance of cancer screening and more late-stage diagnoses, that's really at the organizational level, not at the individual level. So finally, describing determinants of behavioral and environmental risk. So this is phase 4 of your logic model of the problem. So the personal determinants influencing both the behavioral and environmental levels. Determinants of behavior are factors that rest within the individual that can be changed or modified by interventions, and they influence how people think or behave. So it's really important to remember that determinants have to be able to be changed or modified. So if we're talking about a genetic predisposition towards something, or any other thing that's not able to be changed or modified, that really can't be a determinant of behavior, because your intervention is not going to be able to make a change in those things. So you want to consider how behavior change theories, so refer to chapter 2 in your book, and environmental theories, which is chapter 3 in your book, describe how behavior change occurs. Every program plan should be based on a strong foundation of behavior change theory. So when you're gathering data for your needs assessment, there's a few different ways you can do it. First of all, you can use qualitative methods, which would include interviews, focus groups, observational field notes, and then of course quantitative data, which would be surveys, registries, administrative data. So for this class, you're going to primarily focus on secondary data sources. So this is going to be data that's already been collected. You're not going to be collecting any data, and you're going to be looking at large studies that have been done either nationally or statewide, or even locally, to give you information on the needs of your target population. So there's a really helpful table on those pages listed here in your textbook that should help you know where to start looking for that reliable data. And here are the references for this lecture. And just a tip for your needs assessment for your first assignment is make sure that you really are using very strong epidemiological sources for your incidence and prevalence and however you're characterizing your needs assessment for your target population. While you might come across studies that have been done in a very similar target population If it doesn't have a very large sample size and has not been done rigorously among that population, it's really hard to build your whole health promotion program on top of that. So you want to be looking at really large data sets. These are all publicly available, easy to access. So if you have any questions about that, please let me know.